co-hosting this panel with Dr. Jonathan Bringas-Dimitriadis. Thank you, everyone, for being here.
Thank you, everyone, for being here. My name is Jonathan Bringas-Dimitriadis. I am a medical doctor and a digital health expert. I'm really happy to be hosting this with Hansa Bhargava, and today we have a really amazing panel. With us, we have David Alberts, we have Robert Cowell, and we have Ami Bhatt. The three of them experts in not only about cardiology, but also in innovation and medical technology. And we're gonna let them introduce themselves one by one. We will start with Ami.
Thank you so much for having me. Ami Bhatt, I am a cardiologist at the Mass General Hospital. I was trained in medicine and pediatrics, take care of adults with congenital heart disease, and I'm now 7 weeks into being the Chief Innovation Officer at the American College of Cardiology. Really honored to be here and to talk about telehealth and digital health and innovation and everything good that is to come in cardiology.
Thank you, Ami. Next, we will have David. Welcome, David.
Yeah, I'm David Albert. I'm the founder and chief medical officer of AliveCor, and I left academic cardiology at the University of Oklahoma after training at Duke 30-some years ago to start now my 4 companies. In 2001, I sold a company to GE and became the chief scientist of GE Cardiology for about 3 years. And the good news is I get to continue to be in academic cardiology. I was co-authored about a dozen papers last year. And I have a presentation at the American College of Cardiology in 2 weeks. So I've been around innovation for several decades, and that dates me, Rob.
Finally, we will have Robert Cowell. Hi, Rob. Welcome.
Hi. Thanks for having me on. I'm Rob Cowell. I'm an electrophysiologist, practiced for 17 years in the Dallas area. And then 5 years ago, in 3 days, will be the anniversary, I joined Medtronic as chief medical officer of what was then the cardiac rhythm heart failure business, really covering all 3 of the arrhythmia businesses. And in addition, have picked up the role of running strategy and business development for the cardiac rhythm implantable space.
Wonderful. Well, thank you so much to everyone for being here. I know how busy you all are, and obviously exceptional backgrounds in the innovation space. And thank you for all that you do for patients. I'm going to kick off by asking, actually, and this is something that all physicians are wondering, and certainly I had a great discussion with Rob the other day about this as well. And that is really, what is the impact of new medical innovations in the workflow of a clinician, and in this regard, of a typical cardiologist? So I'll start with you, Ami, and then we'll go from there.
I love that we start with this question. There is so much innovation that is ongoing, scientific innovation, care delivery innovation, understanding data. And we have for many years faced this challenge that we call of provider or system adoption. And I think the challenge behind that is, in fact, workflow. We have workflows for how we perform clinical medicine, for how we care for patients. We don't have workflows for a lot of new innovations. We've gotten better on the science side, and we've gotten better when we think about medical grade devices in creating what that workflow should look like, oftentimes because that's sometimes subspecialty based and allows for subspecialty societies or groups to think about how to do it. When we start to think a little bit more broadly about population health, and we start to bring in larger swaths of data and say, how will we analyze it and present it to people? When we bring innovations about care delivery out, I think the most important thing we can do is work on thinking about what that workflow is and how it fits. Now, the one other thing we realize at the ACC is we serve a lot of different types of people and practices. And so there is not a one size fits all in care delivery. And so that means multiple workflows. And so it's really an entire area that needs to be invested in. And I would say collaboratively, between the individuals using the product, between the companies that are involved in making the product and thinking about its best use, and the societies that can support that more globally. So I think we have work to do there. We've done it well in the scientific side, but I think in care delivery, we need to start setting up systems. And I know a lot of people are working on this along with us.
Absolutely. I completely agree. Rob, do you have thoughts on this?
Yeah, no, I agree exactly with what Ami was saying. I think you got to think about technology in two ways, right? Or innovation in two ways. There's the technological advances that one needs to, let's say, treat a disease or communicate. But if you don't change up the model on how you deliver those, you can't realize the benefits. And I think we have two examples in the last 2 years very clearly. First is remote monitoring, which I know Ami, was an early adopter of. And for example, you look at the different capabilities of monitoring implanted or wearable devices. A lot of the technology was there and waiting to be used. And it was only during the pandemic that got unleashed, and there was really this strong need to actually change. But it was there, and the change could have occurred. It needed that push. And so very little technological modification had to occur to get people rapidly using this in clinics. And that's one. I think the other one, you could see with the work that, kind of Dave or even companies like ours are doing, right? So there's a lot of recent clinical evidence about treating atrial fibrillation earlier in a variety of ways. And then now you've got new ways to diagnose it earlier, where you don't even have to go to the doctor to get a diagnosis. Now, that's all well and good, but to really see the true benefit in getting patients cared for earlier, how do we upend the kind of the classical referral models that we have that slow everything down? And those are where the real breakthroughs come. But those are the really hard things to take on.
It's an important question for sure. I'm going to hand it over to Jonathan for the next question.
Yes. I really like, by the way, the comment from Ami and Robert. I think there are many things that we are still doing wrong. If you think about Europe, for instance, prevention is not even reimbursable. And then, of course, if you don't start from that point, then screening, you don't reimburse either. Then how do you actually do that workflow and create that workflow to actually enhance the efficiency and efficacy of care? So definitely interesting points. The next question that we have is for David Albert. So we are talking about innovations, and we just heard about wearable devices. We just heard about portable devices. So my question is, what are the most vital or let's say essential characteristics on an innovative product in cardiology that you would consider? Is it the amounts of leads for ECG remote monitoring device, or what type of characteristics would you consider are vital?
Well, first of all, Ami and Rob both talked about workflow and that innovations must be integrated into the workflow. And I bring back to, I know someone who's probably all of our friends, my friend Eric Topol, who wrote a book, said the patient will see you now. That turns our workflow and our whole idea of medicine 180 degrees. And innovations, as he also said, my patient comes to me and says, I have atrial fibrillation. What do we do now? That is, came with a diagnosis. Okay, so these are the things we're confronting and how we integrate them in. I will tell you, what the best ECG is? The one you have with you. Just like the best camera is the one you have with you. And so a long time ago at a medical meeting, a very prestigious meeting, and oh, by the way, Ami, the chair of that meeting was Dr. Brownwald. He was sitting right over to my right, and he signed his book for me. I really appreciate that. I had a question. A guy got him and goes, a single lead ECG, it's not a 12 lead ECG. And I said, you're absolutely right. But how many leads does an ICD or an AED use to decide it's going to save your life? And the guy went, one, and he sat back down. So again, if we can use a single lead ECG, a multi-lead ECG, our standard 12 lead, they are different. They have different capabilities. But the best one is the one you have in your pocket on your wrist. And I think we're learning to use that. But now we need to learn how to use that and integrate it into the workflow. And that's been a huge challenge with what I'll call, consumer available. They may be medical devices, accurate, FDA cleared, but consumer available devices, and therefore we have consumer generated data. And physicians don't need more data, they need more insights. And that'll jump us to our next topic of AI, because it's going to be critical.
Yeah, absolutely.
Whether it's an ILR, Bob knows what you don't want to be overwhelmed by ILR data or by personal ECG data as a physician. We've got to be better.
Yeah, and those are such great points, Dave. I do agree with you. I do have to ask, just to be devil's advocate, since I've got so many cardiologists here. So when, and I think I talked to you about this, Rob, but when a patient comes in and they have the one lead data, right? Or if they're going for a run and they start feeling ill and they look at their watch, for example, and they run it and the watch says, oh no, you're good to go, but the patient's actually feeling ill. What is the impact of, false positives or false negatives, in terms of the holistic patient? And how do we cope with that as we deal with innovations? And I throw that out to anyone who'd like to answer.
Yeah, I'll start briefly because, Dave mentioned false positives. That's a huge problem, particularly from the clinician standpoint of getting overwhelmed. And I think one of the things, as we think about how you deploy AI onto kind of that data set, it's less in my mind about how you rank order things, but just how you eliminate unnecessary information. So that's from the clinician side. I think from the patient side, what's hard to understand on the consumer side is, what is the sensitivity of these devices? We have a sense of what their specificity is, and I'm not talking necessarily like the FDA cleared stuff, right? I mean, because there's criteria that have to be met there. But when you're just looking at, is my whatever sports device gonna detect my AFib? It's one thing to know when it's found. Is it going to provide a false sense of security if nothing is found? And we don't know anything about those things yet. And we've got more to go, more to learn. They may be fine. We just don't know yet.
Yeah. Ami?
Yeah, if I may, to combine two things, one, what Dave said and what Rob said. When we think about using innovative technology, right? So advancing technology, one of the important things is it's not an all or nothing. So just like a televisit with a patient is sometimes appropriate, or in person, or texting to control blood pressure, right? There are different ways. Similarly, I can see great uses for the single lead versus a 6 lead versus a 12 lead. And so I think it's important when we have these conversations to remember that all of those are necessary, and it's okay to sometimes need to use one and sometimes need to use another. So just reflection on what Dave was saying, because they've done some great work. I would agree with Rob. I think one of the most important things when we think about how our end users, our patients, and our clinicians on the front lines are responding to technology, people need a little bit of guidance as to what to do. We're not the best at health literacy, and I'll say that globally, I think, right? We have, and now we have health and digital literacy. And so I think that needs to be part of the responsibility of industry, academia, societies, to be able to really know that as we are advancing technology and innovations, we are advancing the health and digital literacy that goes with it. And that's perhaps one of the hardest parts. I will call out the Consumer Technology Association and the ACC put together an industry framework that just came out recently. And it's an opportunity for consumer technology companies, people who are interested in the field, to think about what are the areas that you can integrate in cardiology and what needs to come next. And it was done by a great group. I was not involved in the writing group, but I think those kind of documents are also helpful when we work together to start giving some guidance to people as to, here's some ideas of what you can do. It is different than a guideline. It is a framework. But I think those frameworks at least give us a place to get started and say, hey, this framework works here, or no, it's not really working for this other, type of diagnosis. Let's rethink it.
That's such an important point, I mean, about the literacy, right? And I think that as clinicians, especially practicing clinicians, whether they're cardiologists or physicians or nurse practitioners, the time for them to actually intake all of this innovation, because it is such a rapidly moving field, is probably very limited. So, I would ask all of you, with your colleagues, I mean, what is their viewpoint on artificial intelligence or innovations? How much do they know? And, how do we even get to them? Because they need to come to the table, right?
Well, I would just start by saying that the Food and Drug Administration, the professional societies, everyone, every major medical center that I know of around the world is working on integrating artificial intelligence, developing artificial intelligence to try to augment healthcare providers. We don't have enough in many places. There's certainly, I interact with people in India all the time. They have a huge population, a huge problem with endemic cardiovascular disease,
Yeah.
and not very many cardiologists for that population. And so we've got to help people be able to identify those patients who are in most need. Artificial intelligence to triage the patient, artificial intelligence to ensure a proper diagnosis, to make it both sensitive and specific. And that's a critical element. And I think, it's just beginning. Again, Eric Topol wrote a book called Deep Medicine.
Yep.
In that book, he talks about, the potential, really the potential. While we're in there and you talk about, oh, this is great and we can analyze images, we have handheld ultrasound now. That's an incredible tool, but we don't have a lot of echocardiographers and we don't have a lot of echo techs around the world. Therefore, AI to help someone use that tool and interpret that tool will be critical, because it's really easy to make devices and send them around the world. It's not so easy to use them appropriately. So AI is going to be critical.
Dave, I totally agree with you. AI is critical, and it will ultimately make medicine more efficient, more precise, and as Eric Topol says, bring some of the humanity back into medicine too, so that clinicians can spend more time at the bedside. I completely agree with you. I think the question is really the adaptation and the awareness, as Ami pointed out. Jonathan, what are your thoughts on AI?
Yes, well, I think AI is super important. I mean, we are talking about an era in which we have such an overstream of data. And if there's one solution that can actually give us that statistic analysis in a blink of an eye and give us so much targeted information, is AI. If we think about the usage of digital biomarkers nowadays in clinical medicine and also in clinical trials and development, AI will just have a very key role in processing all this data and giving us just trendable information so that we can actually give an action to that information. I do think that what David was talking about, how do we actually associate data to the workflow in medicine, and how can we make medicine more accessible? There's also another key point there, which is education. When we think about patient education, they don't know what's the difference between what a Fitbit tells them or an Apple Watch tells them and what, for instance, a one-lead ECG device tells them. But there's a big difference between the technology originated from photoplethysmography, PPG, and from ECG. And there's also a big difference in the way a doctor can interpret ECG versus what they can interpret from PPG. So there's some education for the patient that has to happen, in which they understand when we're talking about screening and when we are talking about diagnostics, because they don't have that very well divided. And then they come to the doctor thinking that they have something because their device screened them. On the other hand, we also have to educate the doctors of what are these new technologies and how can they be used, so they are prepared to give an action to that feedback.
Yeah, no, those are great points. And, I think AI will certainly help us tremendously. Rob, do you have any thoughts about any issues that we have to be aware of around AI? Like, what are the pitfalls, for example?
Yeah, so a couple of things. I think the power of a machine learning algorithm is going to depend on the input data and the accuracy of it and the inherent biases that come with it. And so I think that's going to be key, that we don't create unintended consequences of applying an algorithm that looks at only one small patient population to a whole bunch of people and miss things. I think there are numerous examples where that's occurred. I think when you step back, I think even beyond AI, when we talked about kind of the digital technology and consumer technology, the other place we're going to be careful about is just access to care.
Yep.
You know, even though these are kind of more accessible and cheaper, do we create even more of a divide among our patients about those who do have access to digital and kind of communication technology and those who don't? And again, there are ways around that. We've done that in medicine and with various success around the world. But we have to be mindful of that. And I think AI is no different. If we aren't using data sets that look at a variety of patients, we've got to be careful on how we apply it.
Totally agree with you, Rob. I mean, you can have bias in AI algorithms, unfortunately. So it is input in, input out, absolutely. I mean, just in terms of what Rob just said about access to care, is that something the American College of Cardiology is looking at alongside with the innovations? I mean, we can't leave people behind. It's absolutely true.
Absolutely. So, since the birth of the innovation group 6 years ago, the concept of making sure we don't worsen the digital divide and that we have an equitable look has existed both in that part of the program, but really throughout the ACC. It's one of our key pillars. Um, I guess two reflections on that. So one is I will tell you the ACC program in innovation moving forward ourselves. Our goal is to have equity at the center and really part of the fabric of what we do, not a project, not a pilot, but part of the fabric of how we approach thinking about technology and innovation. I want to go back though to the concept of AI and our clinicians for a moment, because I think so. There's two things I want to point out. One is I love the phrase AI enabled, the idea that people understand what the AI is supposed to do for you, how it is supposed to gather this data and raise all the data that's out there to a level to create a new foundation upon which you are supposed to use your clinical acumen. It is not a replacement of your decision making, but an ability to take large swaths of data that a computer can do better than a human brain and then allow you to do that. So I think being AI enabled is important. Understanding exactly how that machine learning worked or what the deep neural network was, that's perhaps asking too much unless someone has a real penchant for it. So one is just the concept of being AI enabled. The second is a little something I've been working on, if you'll allow me, but Rob really led perfectly into it, which is artificial intelligence. Artifice is actually defined as clever or cunning devices that are used to deceive others. So I would say that I think the barrier to making
Yikes.
innovations such as AI trustworthy may really have its foundation in that definition. So I have been trying to use, and I am writing a paper and really trying to get down on collaborative intelligence, which incorporates really what Rob just said, which is we as the clinicians, as the community of healthcare, think about what is the data input that is going to be used for whatever version of computer analytics we're doing. Is it federated learning? Is it machine learning? Is it a deep neural network? And then we take the output and we say, do we see that this output seems clinically relevant, unbiased? There'll be times where we see things where we say, no, we're right and this is wrong. That's okay. It's not a failure. That's an opportunity for iteration.
Yeah.
And there'll be times where, the computer will say, hey, you're not right. I can see this better than you can. And that's okay too, as long as we confirm that we agree that that's clinically relevant. And so I think we'll see both things. But again, I'd like to get rid of the word artificial in healthcare. I'd like us to start thinking about collaborative intelligence. And I really think being AI enabled, understanding what the AI does, not feeling like as a physician, a nurse practitioner, a PA, that you need to understand what the AI did there because it's just too much to take on, unless, again, you have a real interest in that.
I completely agree, Amy, and I wonder if it's good to have some some sort of analogies in terms of or exact clinical scenarios where artificial intelligence could really help the clinical acumen to have clinicians better understand that. And I think Isaac Asimov did not do us any services with AI, and neither did the movie AI, if anyone ever saw that. Like, that was years ago. Now I'm aging myself. But yeah, I think, and I think it's hard to understand if you haven't really dived into this.
There's a great example in heart failure preserved ejection fraction, where a group of cardiologists got together and really did feed some computer analytics to machine learning, and said, here are the different things we look at. And whereas the heart failure cardiologist could always say this is heart failure preserved ejection fraction, the computer was actually able to find 3 different categories of patients, the third of whom was more likely to be admitted. And that was using data that the heart failure cardiologist had thought was important, but seeing trends that perhaps the human brain can't see with these large volumes. And I think that trend recognition is such an important place where we can start speaking to clinicians about its utility.
Absolutely. And it's just so vital. I've been working on a paper for pediatrics along with Jonathan, actually, and Diana Benston, just utilizing some of those concepts. David, do you have, sorry, Dave,
Wow.
What are your thoughts on the pluses and minuses in a clinical setting of artificial intelligence, and
Well,
in terms of
Rob mentioned one word that is getting more attention: bias.
Yep.
We've seen, I just read a paper from New York City, from Mount Sinai, on using the ECG to identify people with low ejection fraction, something that'd be excellent. Everybody here may know that my friends and colleagues at the Mayo Clinic have done something similar. Guess what? Olmsted County and Manhattan are 2 different populations. And I think what we have to worry about is, do these models travel? Do they generalize? I was at the ESC in Paris several years ago when there was a paper, a study of normals, echocardiogram normal values, left atrial dimension, et cetera. And guess what? The Chinese data was not the same. Their normal was not the same as Western normals. And so I think we have to worry about bias when single institutions with different demographics develop models. We need to be able to test them on a global basis across different demographics and to gain confidence in them. And I think the Food and Drug Administration knows this now. They've put out a framework of how to evaluate these things, but I think we all have to do it. And again, Rob mentioned it, just an ECG analysis. You can have populations will be biased. And one of the things that I think most people love, sensitivity and specificity, the reality is this thing called prevalence and positive and negative predictive accuracy. We take the same tool, and in different populations, it can be more valuable or less valuable, can generate more false positives or less false positives. And that just has to do with population. So we need to be careful, because AI is not perfect and it's not magic. It's still dependent on the data. And if the data has bias in it, the AI can have bias in it.
These are such great points, Dave. And I think that I look back at something that's not AI based, and that is, I am a pediatrician, and I mean, you have a background in pediatrics, Jonathan, and the growth curves, that you're looking at, right? And matching kids against those, especially in a population in the United States, which is increasingly of Latin American background or African American, and even Indian. I'll just say my own kids were falling off those growth curves because those growth curves were based on mostly a Caucasian population when they were established. And so, to your point, Dave, it really makes a difference in terms of what's going into the AI and the ability to be precise and have those norms. And to that point, I ask, does it make sense, as we kind of are at the beginning? Well, not the beginning, but we're kind of at the edge of, as some people say, exponential medicine here. Do we need to have open source data? And I'm going to throw that over to Jonathan.
I think definitely. I was just reading an article the other day about socioeconomic responsibility when risk for hypertension. And that's incredible because we were when you see all the risk factors of hypertension, and some of them are being African American or coming from Latin American descent, because those are more um, at risk populations. And then you say, well, more than that, actually socioeconomic and a negative net worth is even more responsible for hypertension. Then we have to also consider a lot of other things. It's not only about racial demographics or gender, age. It's also socioeconomic background, and those have to also be part of the general population when we talk about clinical or academic research, if we actually want to have some clear answers to healthcare questions. So definitely open sources of data. There are several universities that are already collaborating with open sources of data, like the University of Edinburgh has a really big open data library that they offer for academic research and also for some types of clinical developments. And I think those initiatives coming from several universities in the world will actually open our eyes to what is epidemiology, and how can we actually develop solutions that are more oriented for absolutely everyone. So, and of course, at the end of the day, that development, it really will enhance healthcare in different parts of the world.
Any other thoughts on this, Rob?
Yeah, I had a little bit of a separate thought from before. So if someone has a thought on this, I'll let them go first.
All yours, Rob.
All right. Yeah. I want to go back to this kind of idea that Amy brought up about AI enabled, or, Dave, you used a great word of augment. And, we get hung up that the only place where AI can really make a difference is in diagnostics. And in fact, that may be one of the most difficult places to bring it in, because we've all been trained on this pathophysiologic approach, and then you put a black box in the center of it, and it is really tough for physicians to deal with. Let's not forget that AI can be great at augmenting or simplifying the daily routine of our lives. And so, Dave, you brought up, helping get better ultrasound images. Huge place where you can democratize healthcare with that. The simple things around natural language processing and simplifying, creating a note, complication reduction. For example, in industry, how do you use AI to look at device surveillance so that it's in the background and happening all the time? These aren't as captivating and headline generating, but in a lot of ways, they can have huge impact on our day-to-day lives in healthcare.
If I may say something really quick about what Rob just said, AI being used in other moments of the patient journey than only in diagnostics. I would also want to say digital therapeutics is an incredible usage of AI. If we think about, we go to med school, we learn hypertension, this medication, that medication, and then tell your patient to eat hypocaloric and low fat and do exercise, and that's basically just life habits that the patients have to have. When we want to actually create adherence to these life habits, what better solution than digital therapeutics? And then we're talking about individualized digital therapeutics by actually using that AI. I think it's a great usage that would definitely make our patients more adhered, and per se then enhance their healthcare.
Absolutely.
Yeah, absolutely. So as we have just a few minutes left, I have one last question to ask everyone, and that is, one of the things that we referred to before, as we talk about artificial intelligence or wearables, digital, all of that, innovations. How do we bring the practicing clinician to the table? Is it education? Is it awareness? I'm just going to go around the room and just, ask everyone. Dave, let's start with you.
Well, first of all, everybody's seen the pictures. If you don't have them, I have not only kids, I have grandkids, and my 2-year-old can use a smartphone. Okay, so the chief technology officer of most families is a teenager if you have one in your house. And I think they will educate the rest of us if we aren't directly involved in technology. That's true physicians also. I mean, physicians don't live in isolation. They have families, they have friends. And so I think, as everyone as generations move on, digital natives will take over, and they will simply assume. I would tell you the complaints we hear about electronic medical records today. I have a 32-year-old son physician. He doesn't have them. Okay.
Interesting.
I have a wife physician, academic physician. She has them. So I can tell you, and she can type fast. She's a 100-word-a-minute typist. She still has them. So I think we will see an evolution as digital natives take over in medicine, and I'll say that will be true not only of the physicians, the providers, the nurses, but of the patients. And so it'll slowly happen over time. It's not going to be a step function. And so they will accept and adopt innovation as the population in general does. There's still, the future is here, just not evenly distributed. Well, that's true about innovation. Innovation's here, just not evenly distributed, and it will slowly work its way into the general population, even around the world.
Great point, Dave. It's coming, so get on the train. Rob, over to you.
Yeah, no, I totally agree with what Dave is saying. It's true in my house when you'd see an 18-month-old playing with a tablet and then get to a magazine and try to press things. I mean, it just shows how when you grow up with something, it's different. I still think there's a lot of power in champions. I think all of us on the call in some way or another have championed something, and you bring people along. And again, I think the last 2 years have been hard, but a lot of change is about people interacting with each other. And so I think that's going to always be a part of any new movement or change.
I do agree with you, Rob. Ami?
I guess there are three things that I really hope we all can do together moving forward for their clinicians. So the first is innovation is not limited to innovators. And I think that is really something we need to get out there. Everybody who's trying something different, finding a new way, and we've all done it in the past 2 years during COVID, if not before. And so I really want us to see innovation as part of the fabric or culture of medicine, especially cardiology, and not limited to just a few. So I think that's really important. I think the second is agility. We talked about this a lot, being able to use a technology in one type of area and then another. And being able to take something globally and bring it back, but also agility to say, I need to iterate on this because it's not perfect. So people say, there's a culture change happening. And I would say that today, the culture is the fact that we now have a change culture, and that's not going away.
That's right.
Things will keep changing, and that's just going to be the way it is. So we have to get used to that. And so I think agility is probably the second thing. And the third will just be a plea based on what Jonathan said, which is as we all move forward and we think about what are social determinants of health, that we all keep that at front of mind. As we were talking about different populations and hypertension, where are the food deserts? Do you know? Do you have an idea? And I think we need more data on that kind of information. We are working in a vacuum when we're just doing clinical work and not taking into account the rest of the patient. And that data is less structured. So as we are thinking about the data we're bringing in, if we don't bring that data in, then we'll probably be biased anyway because we didn't consider it. So just a plea for everybody to start thinking about how we're going to structure that data and include it.
I love that
Thanks
point,
again for having me.
No, of course. Jonathan, any last thoughts?
Yes, on education. I'm really, really happy to be part of an education initiative. I just recently joined the faculty of the University of San Marcos, which is one of the oldest universities of the Americas, in their first Masters on Digital Health. Happy to see all these doctors involved and just wanting to learn more about digital health and digital solutions. I think that we have to continue to do this. We have to continue to educate our colleagues, show them what are the possibilities of digital in terms of healthcare, AI, etc. And of course, we have to have also initiatives of education for patients. Those are the most important factors, some of the most important factors to actually be able to implement and leverage adoption of digital solutions.
Absolutely. Some great points made here, in terms of all of those topics, but I really think that I agree with all of you. Dave, yes, the change is here. Yes, we have to be agile, but And yes, we need champions, but we also need to continuously scope for other factors to make sure that access is across the board, whether you're urban or rural and whatever country you're in, whether it's global or local. And, great discussion here. I just want to take a moment to thank all of you for your time. I know how busy you all are. And also to thank our Medscape audience, for further questions for anyone, we will go ahead and provide the contact information. Dave, Rob, Ami, is there anywhere on social media that our audience can reach out to you if you have any questions?
Well, I'm on Twitter and LinkedIn. So those
wonderful
social networks, you can reach out to me. I would say one thing. I want to bring up one thing.
Sure.
We had an entire session about innovation, and there's one thing nobody brought up, which is critical: the money, paying for innovation and innovative new ways. We talked about integrating into workflow. Well, why do we do that? Because that's how we get paid. And I think one of these days we're going to have to, Ami brought up televisits. Yeah, but what happens when they don't get paid? Well, then they're going to go away. I mean, these are money, unfortunately. When they tell you it's not about the money, it's all about the money. And I'm not just coming from a commercial perspective. We're talking about payers. We're talking about patients. We're talking about institutions. And I think one of these days you need to have a session on where do the economics fit into the innovation.
Great point, Dave. And certainly we can continue that in our next discussion for sure. I completely agree with you. All right. Well, thank you so much, everyone. And till next time, this is Hansa Bhargava signing off.
Thanks.
Thanks.